had a very difficult, interesting patient a few weeks ago, illustrating the complexities of medicine and how right decisions are really, they don't exist basically. So let me start by telling you my success. It's one of those cases where you look and you say, wow, I really made a difference. There's two aspects. One is this lady came in, she was having trouble breathing, and she was using quite a bit of oxygen. So they said, well, it was thought heart failure versus pneumonia. But, because she had gunky sputum, it was pneumonia. Regardless, she was still on a bit of oxygen, not really getting better. So I said, well, pneumonia, let's go with it. Let's push the pulmonary hygiene, get her to do a status barometer, flutter valve, blah, blah, blah. But she was still on all oxygen. It wasn't really going down. And regardless of what you think, and I would say if you think that the nurses don't titrate very well, I completely agree. But they're 99% on 4 liters. Somebody's probably going to mention it, notice it, and they might go down. So her oxygen wasn't getting better. And so I was like, well, heart failure, her BMP is pretty high. It's a few thousand. She's obese, so that means something. Could it be? They tried diuresis, didn't work, but why don't we try some lisinopril? Pressures are soft, but doesn't mean she can't tolerate it. She has some mitral regurgitation. So give it a shot. Her oxygen requirements came down. She didn't diurese more, but her BMP was below 1,000 after a few days, from 4,000 to less than 1,000 in a few days. That's pretty decent. So she came off oxygen. She was at night, but that's a whole nother thing, probably sleep apnea related. The next thing was moving. Plain up pains in all her joints. Her shoulder, she refused to move. So I asked the ortho, he said the shoulder, let's get an MRI, we all something joint, that's fine, sign on. But I heard screaming coming from her room one day, and that's when she was working with therapy. It's like, yeah, that's sort of, not so great. What can I do? So finally I put her on scheduled Indocin. She said she tried things like ibuprofen scheduled before, 600 milligrams, which is a decent dose. But Indocin really changed her. She was like moving around. I mean, she was feeling great. I felt it really made a difference in her life, right? Because oxygen's one thing. It's limiting to be on oxygen, but the bigger thing is she can't move. She's just in painful. And so I was following up and saw what happened. And it's very interesting because you see the time course if you look back weeks later. Because she's readmitted to hospital. She actually coded. Interesting. So let's go back in time. Reverse chronological order. She coded. She came in for dyspnea. She coded. It says hyperkalemia. Going back a step further. The doctor after me discharged her on Indocin, even though he really didn't want to. And then after a day, he thought better of it and called her and said, you shouldn't be on it. He had stopped lisinopril because he didn't want to combine the two. He said her heart failure wasn't too bad. She's still on a beta blocker. She's already on amiodarone. Her heart was fine. Probably 120s. But, I mean, lenient rate control. 130s, right? Who knows what's the optimal rate anyways. She was tolerating it. But basically, did I make the right decision giving her Indocin? He thought it was bad for her. He didn't deny it helped her. Absolutely. But what about it? Does it have risks? Because it had longer term risks, he was saying, to her kidneys. So he couldn't be on it. He only gave her 2 weeks of life, but he really didn't want her on it. So after she woke up in ICU, after she was extubated, she complained of her joints again. And the intensivist is going to do an expedited room workup to see what he could give her to help her. Because there's better agents if you have, say, rheumatoid arthritis. But here's the thing. This illustrates the complexity of medicine, because really, what is it that the patient wants? If we're believing the patient's the one in charge, they have autonomy, and we try to help them achieve their goals. Her first and foremost is moving, right? She wants to move. I mean, you could say she may not really understand the risk to her kidneys and this and that, but hey, she wants to move. Now that she's awake after being saved in ICU, she wants to move. And she can't because her joints hurt too. She normally lies rigid like a statue. I mean, she was literally screaming into the hallway when they heard her working therapy. They didn't even get her up yet, as a standing. And after that innocent, she was just really bad. It's like she realized, my body works, let's do some dancing, right? You know, people have choices in life. See the guy who comes in for GI bleed from his anticoagulation, but he doesn't want to have a stroke. We say, well, yeah, I mean, you've made that decision in life. You'd rather bleed than have a stroke, so let's put you back onto your anticoagulation after we stabilize you and you're alive. But do we have the choice to move? What's the point of being alive if you can't move? Is it like being in jail? Jail in your own body? So you're not on oxygen. Your kidneys aren't failing. You're not going to go into cardiac arrest, but you just can't move because it's too painful. What's the point of living then, right? The other thing that's interesting is you look at the time. The doctor was saying long term is too risky, right? Short term versus long term. I see this all the time. Surgeons, simple-minded creatures, I'm just kidding. They think about short term, right? Gotta save this guy. They gotta be a hero. So I've seen this twice. I mean, it happens all the time, right? So one was the lady is probably gonna die, but you gotta operate on her to give her a chance. So she already ruptured her intestines, had it perfed days ago. It's just because she was on high dose steroids for another reason, like 80 milligrams of prednisone, that she didn't have that many symptoms. Never had acute abdomen, no peritoneal signs. Anyways, CT showed it. The surgeon offered to operate, but she didn't want it. She didn't feel that bad. It's a risky surgery. Until finally, at his consultation, 3 days later, she's already perf for 3 days, already been on antibiotics. What are you gonna do now? So they took her and they pulled her off life support a few days, right? There's no point. I saw again recently, there's a lady who started leaking through her belly button, ascites coming out. She started doing poorly, but her family insisted she's not that bad, blah, blah, blah. Anyways, so she went through surgery, was in ICU afterwards, didn't regain any coherency, and they, again, pulled the plug. So, the surgeon's perspective is, I'm gonna do this to give you a chance, right? So, let's talk about short-term, long-term. Short-term, beneficial short-term. Long-term, not beneficial, right? But is that true in life? Many things we do short-term are not beneficial long-term. How do we decide, right? We let many people make bad decisions short-term that are not beneficial long-term. As a medical professional, am I supposed to help you achieve your goal if that's what you want? Or does my knowledge come into play in this whole short-term, long-term decision process? Because I can think more long-term than you, presumably. And I'm not supposed to wait the long-term goal for you because you can't do it yourself. But going back to this very interesting case, did I do the right thing? Did I help her? I have to say objectively I did. Was it good for her? Can you know the future? What are risks anyways, right? Can some people tolerate NSAIDs, high dose for a long period of time, better than others? Absolutely. How do you know who can and who cannot? Maybe there's some scoring calculator I don't know it. But does it really matter? Because we give people medications that have risks all the time. And we say that's life. Treating illness. But what is the difference between illness, disease, and all that such? We learn about it. The technical difference, right, between disease and illness. Illness, how it affects you. Disease is just some medical process going on. But does it really matter? It's how the person feels. They want to feel better. Do they want to feel like they're living longer? Is feeling better and having this quality of life here for a short period of time the same as living longer without quality of life? We don't think about that except for palliative care, old people, blah, blah, and terminal conditions. But I think it really is something to think about just in the regular practice of everyday medicine. Things all have risk. We give people Tylenol all the time, Tylenol. And every now and then somebody has some injuries. Is that okay? Just acceptable? Anesthesia sometimes you have side effects. Antibiotics and negative side effects. Low risk doesn't mean no risk. It's supposed to be a benefit calculation. But how do we even begin to think about risk benefit? Right? Benefit of what? Is feeling everything? Is living more? Is having your limbs so important? Or is it on your head? You can survive with your life intact and your limbs gone from, say, toxic shock, necrotizing fasciitis. Is that good? Medicine's not complicated. It's actually rather simple. And the answer is we don't know the answer to these questions. And I don't think there's a right answer to many of these questions. How do you decide? I don't know. But that's life. We don't know the answers to life. Why do you think we know all the answers to medicine when so much of it is not about medicine, but rather about life?